So welcome, welcome. Today we have Robin and Danielle joining us from very far on the East Coast. Thank you for being here with us, you guys.
Oh,
Um,
thank you.
and they're going to talk to us a little bit about ethics, LGBTQIA affirming care, an ethical imperative. I will stop sharing this title slide and hand it over to them, and they can go ahead and get started. I will do my best to facilitate the chat.
And we'll also be looking at the chat as we go through the presentation. So if you have questions or things that come up, don't hesitate to put those into the chat. We like interaction and engagement. And again, thank you to Summer. She's going to be helping us by putting on the screen our slideshow. I normally am in Hawaii, but today I am not. I'm over in DC, Washington, DC. For a meeting, but I'm grateful to be here. And I'm also really happy and grateful to have with me Danielle Phillips. If you want to put some of the presentation up for us, we'll work through the slides. We'll go to the second slide and we'll do introduction.
Let me get that going.
And I will keep adding people in as I can help with that too. Okay, there we go. If you've ever attended something that I've done on ethics, you know that I love talking about ethics. I think ethical decision making, ethics in general, it's a fun conversation and discussion to have. However, I normally have updates to the code of ethics related to social work, and this time not so much. And so I wanted to do something a little different. And that is taking an approach where we're going to talk about ethics through the lens of care, meaning that we're going to talk about this in terms of LGBTQIA affirming care, what that looks like, why it's important, and why we have an ethical imperative, why this is so important right now. My name is Robin Arndt. I am Interim Director of Student Services and Coordinator of Field and Continuing Education at the University of Hawaii at Manoa, Thompson School of Social Work and Public Health. I'm also secretary on the National Association of Social Workers Board of Directors, and I'm a commissioner with the Council on Social Work Education for the Commission on Educational Policy. And today I'm joined by an alumni, a graduate of the Thompson School, currently pursuing her PhD, Danielle Phillips. Danielle, why don't you go ahead and introduce yourself?
Hi, everyone. I'm so excited to be on this call with Robin. My name is Danielle. I use she, her pronouns. I'm a current PhD candidate at the University of Maryland School of Social Work. I am the former director of social services at Hale Makua Health Services on the island of Maui. And I'm just very excited to be here.
And part of what we'll be talking about today in terms of LGBTQIA affirming care relates also to work that Danielle's doing right now as part of her dissertation. And so it's really kind of nice to be able to bring in the things that she's working on to complete her PhD as we go through and talk about this topic. We'll go to the next slide. And for all you social workers out there, I just wanted to make sure we give you a little recognition, say Happy Social Work Month. Very timely that today is actually International Social Work Day, Tuesday, March 21st. So for all of you social workers out there, just thank you for all that you do in your communities, for all the work that you do. Happy that we have a month to celebrate all of our accomplishments and everything that we give back to the community. And if you're not a social worker, we like allies as well. And so we thank you for all your service and helping your communities and helping the social work profession as well. On the next slide, you're going to see that we have no relevant financial disclosures to make. And we're going to go to that slide, and then we'll go to the objectives. And today what we're hoping to do is two just very broad-based things. We want to describe LGBTQIA affirming care and outline the steps associated with the ethical decision-making framework and apply it in practice. Again, normally when we're looking at the law for social work in the state of Hawaii, or all of them that govern our different disciplines, it talks about what ethical practices and what constitutes ethical practice for social work or continuing education. One of those elements of the definition is being able to outline an ethical decision-making framework and utilize it in practice. And so that's why we wanted to change how we're kind of constructing this PowerPoint or this presentation today. We have a little bit of an icebreaker different from what you normally do, which is going to be on the next slide. And we're going to ask you if you would be so kind to put into the chat your name and pronouns, if you are comfortable sharing them with us, your area of specialty, where you practice, and what you hope to learn today. So if there's something that you're hoping to be able to take away from our time together, we're just kind of curious what that would be. And you can go ahead and put that in the chat as well. And we'll give you just a little bit of time to be able to answer those questions and look at it. And then Danielle and I are also going to give you some information on what we hope you'll take away from it, but we want to hear from you first. So again, giving you a little bit of time just to answer those questions. You know, there's a lot in there, but we want some engagement from all of you as well.
Great. And while everyone's doing that, if I could just note, I see some new names joining us today. If you are looking to earn CE or CME credits, if you could please change your username to a recognizable first and last name so that we can have your attendance noted for the CE credits to be issued. Thank you.
Thank you, Dr. Weir. Like that, you said doctor. That,
Oh, I saw Helen Barrow. All right. UH alumni. Love it.
we have some child mental health CAMD people here as well. That's great.
That is awesome.
All
right. Another graduate.
Learning anything new better today. Great. Great. And now they're starting to come in, which is really helpful. Again, this just gives us a bit of information on who you all are and what you're hoping to get out of today in this conversation. All over the place. From Guam, we got people from all over the islands. Queens Medical Center. Perfect. And as these are coming in, Danielle, what would be one of the takeaways that you hope people leave with?
I hope people leave with, and so I should have said, sorry, and thank you, Robin, for bringing it up. My dissertation focuses on trans and gender diverse young adults and mental health outcomes from an intersectional strength-based perspective. So for me, what I'm always hoping is I work a lot with providers to see what we're doing well and how we can build upon it, and how that the things we do, it doesn't have to be huge. It doesn't have to be like systematic changes to start, but integration can actually be very doable and possible. And so there are real things that we can be doing as practitioners and helpers that will make a difference in the lives of the people we work with in partnership with.
That's great. Thank you, Danielle. For me, I'm hoping, what am I hoping? I'm hoping that you take away aspects of a ethical decision-making framework, but also getting more into understanding that we use ethics all the time. Like ethical decision-making is something that's ingrained in us that we forget about, but also that there's an imperative, especially as we're talking about LGBTQIA population. Hawaii is a little different than other places in the country, but those things also influence things that will happen in Hawaii, or the patients, clients, people that you'll interact with, especially as we, again, increase with telebehavioral health and providing services across the country. We have to be aware of all these things. And so hopefully, ideally, being able to apply a decision-making framework in practice, but also taking lessons on how to adapt your current services, or maybe you're already doing some of these things, which is even better, to being more of an affirming practice for the LGBTQIA community. Great. And we'll move on, and please keep putting information into the chat. We'll keep looking at it and bringing in stuff as we go through. It's nice to see all of you and to see where you're all coming from, your different disciplines, different areas of practice, so on and so forth. We'll go to the next slide, and the next slide is sorry, we can skip forward one more. This one, which is reviewing the issue through the lens of an ethical decision-making framework. Again, if you've heard me talk about ethics or social work ethics in the past, many times I have to do updates on the Code of Ethics because there have been changes that have happened to social work's Code of Ethics over the last 6 years. But this year, thinking again of what's going on in the country, what we're seeing in terms of suicide rates, murders, attacks on LGBTQI populations, bans on drag shows in different states. All of these things really are impacting the mental health and the wellness of a large portion of our community, which we'll see in a couple slides. And so approaching this from how do we think through this in terms of what does it mean to practice ethically? What does it mean to think through this in an ethical way? On the next slide, you're going to see what we refer to as the ethical rules screen. This comes from Dolgoff, Harrington, and Lowenberg. And essentially what this slide is telling you, you probably have seen this in your own education as you were going through, if you're going through a social work program or other programs. But the ethical rules screen essentially tells us that when we have a problem or a situation, or there's something that's coming up that is causing an ethical dilemma, the first thing that we want to do is we examine the code. For social work, it's called the Code of Ethics, or the code, to see if there is anything that gives us guidance. We're also looking at applicable rules that could be legislature or policy, so on and so forth. And if there is information, if one or more of the rules apply to the scenario, then we want to follow whatever the code says. And if not, if there's no rule that applies, or rules are providing conflicting guidance, maybe on one hand it's telling you one thing, and on the other hand it's telling you something else, then what we want to do is we want to utilize another tool that was also designed by Dolgoff, Harrington, and Lowenberg, which will be the next slide, which is the ethical principles screen. And here you see it on the screen right now. Again, some of you may have seen this, maybe not, but essentially what this is getting to is that when we have competing dilemmas, when there are competing priorities or competing information, or our code of ethics, the things that give us guidance, aren't giving us all the guidance that we need, or aren't giving us a clear direction, how then do we take the information and decide what to do next? And in the ethical principles screen, Dolgoff, Harrington, and Lowenberg, they put protection of life at the top, meaning that at all costs, what we want to do is we want to ensure the protection of life, and that takes precedence, or takes precedence over all the other things. So you can think of this as like a hierarchy, beginning at the top and then moving down, but a way, again, for us to be able to think through dilemmas that we may encounter. On the next 3 slides that you're going to see, the first one here is just a general overview of frameworks for managing ethical issues. In having taught many sessions on ethical decision-making for social workers, practicing clinicians, so on and so forth, when I've asked this question before, like, how do you make an ethical decision? Many people forget that they actually have a process, meaning that you do think through and follow some sort of guidance in terms of how you are coming to a decision on what you're going to do. In this framework, or as you look through the frameworks, they generally incorporate very similar things, beginning with identifying the ethical issue, determining what the appropriate help could be. Is that talking to other people, getting consultation? Is it going to an ethics board? Is it looking at policies, procedures, code of ethics, so on and so forth? Thinking critically about it, managing whatever conflict is going to come from it, planning and implementing the decision, and then evaluating and following up. On the next one, I gave you 2 different versions of frameworks. This one is from Frederick Reamer. Dr. Reamer is a known social work scholar related to ethics. He's constantly sought after for either testifying in court on ethical behaviors for social workers or ethical dilemmas. He's led the charge, not led the charge. He's been instrumental in actually the development of the code of ethics that we currently have for social work in the 1990s. And he's been part of the committees since then that have looked at and reviewed the changes to the code of ethics. But on here, you see, again, similar things. We identify the issue, we identify the individuals, the groups, who can be helpful, or who is this going to impact? How is this going to happen? Then we look at what are our viable courses of action. If we're going to make a decision, what are our choices, what do they look at? Then we have to examine them. That would be the critical thinking part of it, looking at the codes of ethics, legal principles, thinking through theories, guidelines, policies, and then there's also the consultation, and then lastly, making the decision, documenting the decision, and then documenting the process for how you made the decision, and then always that monitor, evaluate, and document. The other one that we're going to show on the next slide is a more simple version of this, and this is why I like it. The Reamer, I really love. I think that it's really comprehensive. This one is the one I remember, though, because it's built on things that I learned in elementary school when I was learning to be a little reporter, right? The who will be helpful in determining what the decision is going to be. What are your choices? When have you faced a similar dilemma? Where do the ethical and clinical guidelines lead you? Why am I selecting this course of action? And lastly, how do I enact my decision? So again, very similar in the formats as you see this. And these slides are also going to be made available after the presentation. We're going to be up on the website as well. So you'll have copies of these things moving forward as well. But for you, and you can put this in the chat as you're thinking through this, and you don't have to answer right away, how do you currently, what is your process? What do you currently do when you are faced with an ethical dilemma? And if your first reaction is, I don't ever face an ethical dilemma, pause for a second, because there are so many times in a day where I think you do actually face some ethical conundrum that you have to think through. And you can put that in the chat as we move on to the next slide, which Danielle is going to take over for us.
Thank you so much, Robin. Okay, so I really am going to be talking about the current climate of this topic and why this is something that we should care about. Next slide, please. And so I think when we're starting any conversation, to begin, I wanted to define a couple of important terms that'll help provide clarity. So many of us are familiar with the acronym LGBTQ, but this is a growing acronym and it's living and breathing. And so it's changing all the time. And as a former, medical social worker, I was always like, what are the newest terms that I need to know? And so currently LGBTQIA+, wow, what a mouthful, is a current acronym that most agencies are moving towards. And so this is being adopted more frequently. And it is important to know that there are countless affirmative ways in which people choose to self-identify. Next slide, please. And so, so can you click it once, please? Cool. So to begin, I wanted to define a couple of important terms. And so the terms that I'm really going to be focusing on are some of the newer terms. One more time, please click it. And so most of us know what our standards are, but I really want to focus on the less known intersex, asexual, or agender, two-spirit. And I'm also going to expand a little bit on our concept of transgender. And so the term intersex, when we talk about that, it's really an umbrella term to describe people born with a variety of differences in their sex traits and reproductive anatomy. There is a wide variety of difference among intersex variations, including differences in genitalia, chromosomes, internal organs, hormone production, just to name a few. And so according to experts, upper estimates are that nearly 2% of the general population is born with some intersex traits. And just for comparison, that's actually more than the entire population of Japan if we're looking within the US. So, and then intersex people are born also with different, some of these develop during childhood, or you're born with them. And so I think that's one of the most misunderstood concepts. And so asexual really can also be used interchangeably with ace or aces. And it really refers to folks who experience a complete or partial lack of sexual attraction or interest in sexual activity with others. And so this exists on a spectrum, and people move along that spectrum over time. So it can be a little confusing to try to pin down exactly what that means. As with most things, it's all personal, dependent on the individual. And I think something that is really important situated in Hawaii is two-spirit, which describes an indigenous person who expresses their gender identity, spiritual identity, or social role in a traditional non-Western way. And so this really is each tribal community. It's very commonly used in American Indian and Alaska Native activists. And so this is a term that is unique to tribal culture, society, and terms. So it just envelops that concept. I'd say of all of them, it's most related to what we know in the Hawaiian Islands as mahu. And so also just to expand on transgender, also interchangeably with trans, completely okay. It's an umbrella term again, and it's inclusive but not forced upon anyone who identifies as a gender that does not correspond with their sex assigned at birth. And so I wanted to end on this plus sign. So what is with a plus sign, right? It really exists as a symbol to represent folks who identify with a sexual orientation or gender identity that isn't included with the LGBTQIA acronym. Next slide, please. And so things that, like, for me as a clinician, when I worked, I really wanted to have concrete tools. So I hope we tried to include some of that here. And this is one of them, right? So why do we care about this? It's really because studies have shown that language is often one of the most easily changeable things we do in working in partnership with this community. And it's also one of the ways in which LGBTQIA2S people are harmed the most, right? And so it is important to know, like from my own studies, what I've seen is that people know it's messy. People who are, especially in trans and gender diverse communities, understand that, it's going to be messy and it's okay. And like the understanding I've gotten is if you mess up, no worries, just say, oh, sorry, and correct yourself and move on. Otherwise, you're centering your own discomfort instead of theirs. And so that was a really helpful tool. So I hope you'll take this and look back at it, which is really just terms that are okay to say and things that are not super great to say. Next slide, please. Okay, so however an individual describes their identities, including individuals who are not of gender and sexually diverse populations, we all possess the following components of human identity. In this infographic, again, hopefully you can use this if it suits your needs. But we're always going to be talking about gender identity, expression, attraction, and assigned sex. And so a lot of the times in international human rights work, you may have or hear these components described as SOGIs, which is sexual orientation, gender identity, expression, and sex characteristics. And so I think just being conscious of these different components allows us, especially in positions of privilege and power, it helps us really start to understand identity in relatable and relational ways. And it also helps us establish these components when we're talking about legal implications, when we're talking about protection as, of the community and of ourselves as professionals. And it also really helps us demystify and clarify some of the concepts that are sometimes the hardest to really work within. Next slide, please. Okay. Yeah, perfect. Thank you. So I always think, how big of a problem is this? I always want to know that. And so I think when we talk about the scope of the problem and how many individuals we are talking about, I really want to provide some data. So currently, as of 2022, a total of 7.2% US adults 18 and up identify as LGBT. So that's based on a new Gallup poll taken in a new Gallup poll. And so there has been an increase in representation among trans populations from the last time data were collected in 2017, which also includes Gen Z for the first time. So we're seeing a larger increase. And a lot of the times you'll see an expansion on that acronym and somebody will say, that makes sense for me and my identity. So you know what, I'm actually not this, I'm that. So you'll see a lot of different evolutionary steps that people take in their identities. And so I do want to point out that almost 20% of adults born between 1997 and 2004 identified as LGBT, when compared to 11% of millennials born between 81 and 1996. Click, please. Next, please. Perfect, thank you. And so results from a Gallup poll found that the percentage of people residing in the US who identify as LGBT rose actually 4.5% in 2020 when compared to 5.6% in 2017. So we're seeing this steady rise, and we're going to be if we're in service professional fields, we will be seeing an increase of population. And so, when we're looking at the different groups, I think it is important to think about how we're working in partnership, because along that acronym, right, nobody's experiences are monolithic. And so it is really critical to overall health and well-being to look at affirming models of care. Next, please. Next slide, please. Thank you. And so when we talk about some of the barriers and issues that LGBTQIA2S individuals face, the daily discrimination and stigma is a little bit more visible today, I think, in part due to the anti-LGBTQIA2S legislation. And since 2018, over 670 anti-LGBTQIA bills have been filed. And so this includes a notable Don't Say Gay bill, Fairness in Women's Sports bill, and just a myriad of anti-trans healthcare bills, mostly aimed at youth. And so it is really important to note that of those 670 proposed bills, at least half target trans and well-being. Some on the East Coast where I'm at are coining anti-trans laws as the new war on crime. So we're going to really start to see this a lot more. And so as of 2023, the US has already introduced more anti-LGBTQ bills than in the past 5 years combined. And so according to the American Civil Liberties Union, as of March 2023, approximately 385 anti-LGBTQ laws have been introduced at the state level in a majority of US states. And so by comparison, in 2022, there had been 162 bills introduced, 19 of which were actually signed into law. So this is going to affect us more than I think we kind of realize. Next slide, please. And so I think when we're looking at the scope of the problem, I think a lot of the time it's hard to understand what people are encountering. So LGBTQIA2S individuals face increased discrimination and stigma over their lifetime compared to cisgender individuals. And so more specifically, they experience increased rates of depression and suicidal ideation. Specifically, trans and gender diverse individuals are disproportionately affected by STIs, including HIV, and are more likely to experience victimization related to violent crimes. And so they're also less likely to have health insurance. So LGBTQIA2S populations also experience higher levels of chronic psychological stress and institutional discrimination and lower internalized self-esteem. And I think that's something that when we see it all together, it paints a really jarring picture. Next slide, please. So these negative experiences are also experienced in healthcare settings. LGBTQIA folks report increased rates of stigma and negative experiences when accessing and using healthcare services. These populations explain that medical providers often fail to address the complexities and intricacies of belonging to one of the groups in the LGBTQIA2S population. This specifically relates to over the lifespan as well when individuals are seeking medical care. And this actually leads a lot of individuals to not seek medical care at all. Next slide, please. So I think when we're talking about culturally relevant and affirming care, we have to really stop and look at some of the social norms that can serve as barriers to gender equality and affirming care. And so in an effort to move beyond cultural competence, we really want helping professionals to require a critical self-awareness of our own implicit biases, assumptions, and beliefs, while also remaining compassionate, curious, and patient-centered. Making time for that is something that I think is that inner work that sets apart how we work with individuals in vulnerable communities. And so culturally competent affirming care targets a specific population over a lifespan, includes social and structural equality of care that is relevant to the context in which it's practiced, and it's also grounded in liberatory, culturally based practices. And so when we're talking about liberatory, culturally based practices, we're talking about embracing ethics of raising critical consciousness, empowerment, and accountability, just as the foundational pillars of therapeutic services and practice. And so this can all lead to better patient outcomes as associated with providers who simply have their pronouns on their intake papers, who have them themselves, who understand specific healthcare risks, and who have a commitment to developing knowledge of caring for patients beyond their just their gender and sexuality. A lot of the times when I work with trans individuals, they're like, sometimes I'm just have a cold. It's not always because I'm trans that I'm here. Having that understanding of who you're actually working with. Next slide, please. And so I think in part, if we look at Western theoretical frameworks, which absolutely serve a place at times, but I think we have to look beyond that because Western theoretical frameworks often guide healthcare and treatment options, which are typically assuming people come from privilege and power. And, we're assuming that patients may have that if we are, using theoretical frameworks that are heteronormative, middle-class centered, white centered, cisgender, and treating gender as a standalone issue. These approaches actually lead to treatment solutions that function from deficit models of care. And so solutions are then often, offered as either or, which is a very Western thinking. You can either do this or that. When instead, when we look at different cultures, especially like in Hawaii, we should be really looking at treatment care approaches from both and. So this cultural, that competent affirming care can be both cultural and based on best practices. And so finally, when we're working with LGBTQIA2S folks, then we as helping professionals need to embrace and understand the critical need for intersectionality, liberatory, culturally based, and inclusive practices. Because when we're talking about identities or as it relates to healthcare, we really need to be committed to that. Next slide, please. And so this really brings me to the impact of LGBTQIA affirming care. So these models of care include medical and non-medical interventions that affirm and support an individual's gender identity. It is important to note that these models of care have been linked to decreased health risks among gender and sexually diverse populations. Social workers, because I'm a social worker, helping professionals as well, I've worked on interdisciplinary teams. We all provide gender affirming care by clients by promoting social justice, self-determination, and autonomy within a commitment to practice cultural competence in an integrated way. And so access to gender affirming care is constantly threatened. So for example, as of March 2022, roughly 58,000 trans and gender diverse youth and young adults were at risk of losing access to gender affirming care. And, you know, if you look at the data currently or just turn on the news, you can see that we're starting to take rights away very quickly from trans individuals, especially in the southern states. And so more research really is needed about the positive impact that gender affirming care has on LGBTQIA populations. But these practices embrace the ethics of raising critical consciousness, empowerment, and accountability, you know, when we're in therapeutic practice. And I am going to pass it to Robin.
Thank you, Danielle. And I will most likely be turning my video on and off. My internet has been a little unstable and kicked me off twice already. So I apologize in advance for that in case it happens. Let's go to the next slide, please. And we want to hear from you before we move on. Two things. If there are any questions that you currently have of anything that Danielle covered, you can put that in the chat as well or raise your hand. But also thinking through the information that we've already provided, what are some of the ethical considerations that are coming to mind for all of you? What are you thinking about in terms of where this plays in as an ethical dilemma or as part of your practice? What would be some of the things we want to consider? I'm going to give you just a little bit of time so that you can go ahead. Oh, we have someone that raised their hand. So Renata, right? Renata.
Yeah, Renata. Hi. I'm gonna verbalize it because I think it'd be faster. My question, I have a lot of questions, but the one I think I can ask very specifically immediately is, you know, a lot of people who identify as cisgender or who are very particular, or who are the traditional boy, girl, man, woman, when you look at women who are trying to start a family or who have menstrual issues or other things where they're tracking their hormone levels, oftentimes those things change. And it's often told to those women that it's how they are, like their mind-body connection, that checking certain hormones or being stressed out about it affects how their body is reacting and what their hormones end up doing because of the mind-body connection. And so I'm wondering how all of this concentration on the hormones and just the entire gender issues, how that is either interrupting or making a mark on how we proceed and view ourselves and are perceived in society and interacted with, and just the whole gamut of all of that. And I'm just wondering, you know, like so I'll just shorten this really quick. If it's often told to women, you know, forget about it, just go about your life and do your normal things. And then it often happens that someone either gets pregnant or, you know, their life sort of like takes a different turn once they sort of like put it to the back of their mind and move on doing other things that they would normally do and not be thinking about these particular issues. So I'm wondering how much that affects this topic going forward. And I want to know if there's been any studies or information about that.
Go ahead, Danielle.
I can speak a little bit to this. I think you're talking, and please correct me if I'm wrong, the mind-body connection as it relates to hormonal levels. Am I getting that correctly?
Yeah, I guess in short, yes.
Okay. I mean, there are a lot of studies going on right now, specifically as it relates to hormone levels, how we're defining gender. Are we only coming from, you know, a biological standpoint? And if we are, is that even the correct way to look at this? I think though that when we're talking about does our well-being and our ability to feel like safe and seen in a medical practitioner, and then we can leave and actually just kind of forget about it and not worry about it, does our body relax enough to like maybe get pregnant or any of those things? I definitely think there's a connection between mental health and well-being as it relates to physical health and well-being. I think that's the best I can answer that. But Robin?
I was just going to add, I think, and I can't speak to all the information that you put in the question, but I think even in that situation, there's a room for affirming care for females as well, for cisgender. And thank you for using the word cisgender. I think that's another important term that's affirming in itself, to be able to identify cisgender versus transgender, so on and so forth, using those words. But you know, patient-centered care, this objective that we all work towards, or client-centered care, is important. And sometimes I don't know that we put all of the emphasis on really practicing from that model. And all of that relates to being an affirming practice. It relates to how we ask questions, or how we take the information provided by the patients or the clients, and we take them seriously, and we reflect on them, and we try to find out what the root of the problem is, so on and so forth. So I don't know that we're able to answer all of what you're thinking, but I'm really, what I was hearing from it though, is that it's almost somewhat dismissive in some ways, that there are situations where females, and we could be talking, or we could be approaching this whole thing not for the LGBTQI community, but we could be talking about access to care for women related to access to abortions, or other things. Like, there are a lot of things that are going on right now that are also essential for us to be paying attention to and providing advocacy for, and thinking through, what is this doing for the mental well-being, mental health and social health for everyone. There was another question in the chat. Danielle, could you elaborate and define?
I actually sent a direct message about Halu. I am interested. I wondered, is that something outside of the presentation, or within the slides that you saw? And then if you can elaborate, I'm happy to absolutely answer anything.
And while we wait for that, as we're thinking through sorry, go ahead. Were you gonna say something? Oh, no.
Just put it in the chat.
Okay. We'll put it in the chat. And as we're going through this, so in thinking through, and again, there's lots of different disciplines represented here today. And so we'll approach this from a social work perspective. In social work, we have a set of ethical principles, and thinking through this topic, if you will, and applying it to the ethical principles. We can go to the next slide. All 6 of the ethical principles actually have a place in terms of how we would practice in affirming care. For social work, we talk about service, and service means that we are providing service to our clients, that the resources and information, what we're trying to do is to their benefit, which practicing from an affirming stance relates to. Like, we want to be better for our patients, provide them with the service, the resources that are in need, or being there to help those that are in need and to address their problems, including the social problems that they could get. This is a social justice issue related to access, related to us as practitioners challenging what could be status quo that may not be occurring in Hawaii yet. Although, if you're following the legislature, there were some bills introduced this period related to things related to, one was relating to sex-specific student athletic teams. There was a bill relating to gender transition surgery, related to sex-specific student athletic, that was the same one. So these things are there. I don't know that they're going to move through the legislature. I mean, we did pass last year, and Governor Ige signed legislation that was more supportive of the transgender community and providing access to resources, so on and so forth. but all of our values here, all these ethical principles relate to, again, how we approach this topic, how we provide an affirming stance, how we invite people into a setting and make it so that they feel welcome, that they feel heard, that they know that you'll are an ally or a resource or a supportive person. And the next slide, we can go to the next slide. Again, related to social work and trying to approach this subject through what the standards say. Standards that we would be related to this include things like commitment to client, self-determination, informed consent, even having them understand what they are agreeing to or the services that can be provided. It's a competence issue in terms of how we approach our practice, how we stay engaged with our patients, how you're here today. That's part of being competent and learning new knowledge and applying it to your practice, engaging. Also cultural competence, because there's areas that are related to that in providing a service, privacy, confidentiality, and I don't know why I put referral for services twice. I think the last one was supposed to be termination of services, because in situations where the issue might be outside of our scope, and it needs additional specialized treatment or specialized services, then it's making the appropriate referral and helping the patient or the client understand where they're going to get that information or who could be better for them, but also not abandoning them in this time, but rather providing that area. When we talk about affirming practice, I think lots of things are probably swimming through your head right now. And when you're talking about affirming care, there's lots of various definitions that go on to what it would be to be affirming care. And today we're talking about very basic things. We're not talking about ensuring that everyone should have access to everything, but it's not necessarily about having people go on hormones or those things. It's about how do you provide the atmosphere or the environment to know that someone could approach a subject with you that might put them in a vulnerable state. And again, we work with vulnerable populations, so it becomes really important. I'll put this in the chat later. If you have, I don't know if anyone watches Jon Stewart. What's the problem with Jon Stewart? It's a show, it's on Apple TV. However, he has 2 interviews that are related to this subject that I'll put in. They're short, 3 to 4 minutes. In one of them, though, he interviews the Attorney General for Arkansas, who put in to play many conditions related to gender affirming care. And he has a very frank conversation with the Attorney General about how they came to this decision and all these things. But if you know Jon Stewart, you also know that he is an advocate for a lot of populations. And so he's really doing so to really kind of pull out the hypocrisy of what they did versus what they would do in other situations. The other interview, he interviews people who have children who have received gender affirming care, and they help to define it. And so that's why I'll provide those clips in just a couple minutes. I think that's actually why my internet was not working. I was trying to get that clip. So that was my bad. We'll go to the next slide now. And some of these are going to be taken from resources that we do have on our resource page as well. But this is how we start to embrace being an affirmative practice. First is understanding our attitudes towards sexual minority individuals. Things like stigma and prejudice, they increase the risk for health and mental health problems. Understanding how orientations do not indicate pathology, homophobia, heterosexual attitudes and bias, how they affect our ability to assess and treat clients. My own journey going through and finding services, being able to come out to my own doctor, like that was not something that was necessarily easy to do. I had to find a practitioner that I felt safe with. Because not in every situation is it always the easiest thing to do, or to bring up very sensitive topics in terms of information or questions that I may have. And so thinking about how we can provide that atmosphere, but also thinking through our own prejudice, our own biases, those things that might impact our ability, or the way that we ask questions, which we're going to get to in a couple slides. Affirmative counseling self-efficacy, like this is again the clinician's belief in his or her own confidence to practice affirmatively. Like you can do this, that you're able to actually provide services in an affirmative way. It's the belief that you can help clients cope with their cope with heterosexism or homophobia, understanding what they may be facing, how microaggressions might be occurring, and how you can help them process that information, work through it, and provide them with resources. and having a belief that you can actually do an affirmative practice, that you can affirm the identities and relationships of clients, that you can practice affirmatively, results also in better treatment outcomes for your patients as well. On the next one, next two slides, you're going to see, we're going to go to this one. And there's more information under each one of these. There's a resource link that's at the bottom. We'll try to provide that as well, because this was a really, I think, nice way to break down the steps to become an affirmative practice. The first step, though, is that your organization, your board, your senior management are actively engaged. And this is true for everything that we do, right? When our leadership is engaged in the process, engaged in the belief that everyone should have care, then it trickles down so that it becomes part of the culture of the organization. The next thing that we want to look at is what our current policies say. And so if you look through your organization or entity's policies, do they reflect the needs of the LGBTQIA population? Do you have specific standards or policies related to non-discrimination? Do you have supportive standards or resources available to support persons who may not be married or engage in a traditional marriage, but are living together and lifelong partners? Are they able to visit? Are they able to get resources? So on and so forth. On the next one, outreach engagement efforts, including going and being part of activities that are specific or targeted towards the LGBT community, people in your community. Ensuring that your staff receive training and culturally affirming care for the LGBT population, and then getting into like your processes and your forms that reflect the diversity of LGBT people and their relationships. What do we think we mean by that one, the processes and the forms? What would be an example of some things that you could do to ensure that you are putting out or making it visibly apparent that you are an affirming practice? So sorry. What would be something you could think of related to your processes or your forms? Again, getting you a second so that you can type it, or you can unmute yourself and you can take a chance there.
I gave some.
You gave some things there. This is a good one. Preferred pronoun and name options. And so traditionally on your intake forms, we'll probably say first, middle, last. Adding another line that says preferred name. Again, not being from Hawaii, I'm originally from Wisconsin. Moving to Hawaii, the preferred name became a regular part of all my practice because people I was working with or clients that I would be seeing, they don't go by their given name on their birth certificate. They don't go by, like, it wouldn't be Robin, it would be something else. It wouldn't be Danielle, it would be something else. And so that is a very simple and easy thing to be inclusive. And then one more thing on that would be actually calling them that preferred name and having that be the name that you are using as part of your practice, including if there is a waiting room, utilizing that to call them to get them to come rather than the name that might be in the form. Danielle, what were you going to add?
I was going to say also saying, did I get it right? Just checking in. I think that member checking is so huge. I mean, especially like once I learned to take Hawaiian names 2 syllables at a time, my life got better, but also just saying like, did I say that correctly? And having that humility enough to care, I think makes that relational point so salient. And then even when I talked about waiting rooms, I have individuals like trans individuals and LGBTQIA individuals who are like, I know the minute I get in a waiting room if I'm cool or not, because the art on the wall might be not just a cis family. It might, you know, I see diversity the minute I walk in. And I think that's the level of safety a lot of individuals are functioning from, and somebody who is privileged and able-bodied. And I would never know that. So it's really helpful to think about in all spaces, they are hyper vigilant. Most individuals seeking care are hyper vigilant and usually at their most vulnerable too, right?
And I see some other ones. Leilani, thank you for that. That's great too. Including pronouns on the forms is another one. Asking about family history and having them define what family history might be to be inclusive. Finding, using their terms and their knowledge or what they prefer and asking what they would like you to say is another good thing. That humility though is I think really important, but also giving them permission to correct you because we are going to make mistakes. And it's important though that understanding there's always a power differential, differential that exists between us and our patients, but helping to break that down so that they feel okay to always correct you if I say it wrong. Like earlier, I was trying to say the name, I said it incorrectly, I tried twice, I got the name, now I'm going to say it again, right? Like those little, those things make a huge difference, though. They actually help to really reinforce this supportive nature that you're trying to put out there. Introducing yourself, including these are all really fantastic.
I just wanted to add to echo of what you were saying. In my dissertation work, one thing that I found was that trans individuals specifically, when because a lot of people are transitioning in time, they're learning themselves as well. So they may have changed quickly, and like they understand from my research that it's going to get messy and it's okay to make mistakes. They're just grateful you're trying. And also when we make mistakes, we don't say, oh, sorry, and stay on it, because centering ourselves, we say, okay, oh, sorry, I meant Robin, and moving on and doing the correct thing so that it allows them to also move on with you. I think that was something really helpful.
That's great. And that's also timely because that's related to your research. So that's really fantastic.
Yeah.
Practice informed research, research informed practice. We'll go to the next slide. We have a couple more slides and then we'll go through the resource. We're coming to the end of our time. Some other practices that go into affirmative practice include ensuring that data is collected on sexual orientation and gender identity of patients. Again, based on stereotypes, that we would ask certain questions for certain populations, but making it generalizable so that everyone's getting the same questions. So a heterosexual couple or a heterosexual client that you may be seeing, you should still ask about routine sexual health histories, the same as you would for someone that might be identifying as LGBTQIA. We want to have consistency and we want to make sure that everyone is getting the same information, but also that we're receiving that same information. Clinical care and services that incorporate healthcare needs of the population. This could be putting posters or other things out on the walls in your waiting rooms or in your office, other things that give the impression, again, that you are supportive and affirmative. If you, like at universities or other educational institutions, they have safe space stickers that you can get or other things that can help people identify that you're an ally or a supportive person. That gets into the physical environment, welcoming, making sure that's inclusive of people, and then also recruiting and retaining people who identify as LGBTQIA, right? Getting them on your staff, having them be part of your institution, your work, or your clinic, and making sure that they're staying there, because that, you want to reinforce that, you want to keep that community going. Next slide, and then we're gonna go to the resource list. Thank you, Danielle. I want just Danielle's comment. I want to add that there's power as a provider in taking consumer patients seriously. I can go through all kinds, again, educated.
Being believed is huge. Like someone says they have a problem. Okay, cool. Let's talk about it. Not being like, are you sure? Like, I don't know. There's a lot of this negotiation in these exchanges a lot of the time, and they're my understanding from the projects I've worked on, they can be quite demoralizing, and also it can be very gaslighting for individuals to be like, wait, what is that? What's happening? I don't know. Do I need that test? And it is it's some of the main reasons people don't go back to the doctor. I just wanted to add that.
Yeah, I'm a testimony to that. There are plenty of doctors who I stopped seeing because I did not feel that they were supportive of me or had my best interest in. I mean, they had my best interest, but not the way that I would have hoped. I often talk about when I quit smoking, and I had to go to different providers to find one that actually worked with me the way that I wanted to work with them in terms of quitting. But it was hard, and so. That relationship, again, we're educated individuals, but that relationship, many of us probably have had those experiences. And so if you've had that experience, how do you break it down so that experience doesn't happen for someone else? For you as a practitioner, a lot of this gets to the groundwork and the hard work of doing some self-reflection, thinking through your own preconceived notions, things that you do or say, and wondering if you could say them a different way. When I was a grad student, we were having a conversation about how to ask, I forget what the question was, but it was related to ask if someone sexual orientation, I think it was what it was. And there were these heterosexual men in the group who would be like, well, if I was asked that question, I'd be insulted. And I was like, well, I'm insulted that you wouldn't want to ask the question as someone that identifies that way. And so what are those preconceived notions? What are the questions? How are you interacting and engaging? Creating that affirmative setting, getting involved in your community, being open to your commitment, providing that therapy that's out there, that affirmative therapy, and acting as an advocate when you might witness heterosexism or others and others forms of discrimination and challenging it so others can be informed and aware. We're gonna skip the next slide and go to the resource list. Thank you. Yeah. Again, this is going to be available on the website as well. So you'll have all of this, but we just wanted to make sure that you saw that we do have some resources that are out there, things that you can take advantage of. The AMA has some great resources as well. These are things, though, that can be helpful as you're thinking through your own practice and how to, again, go about providing that affirmative care. Go to the next slide, go to 35 and more resources. Then the last one is just one more slide for us, is just our contact information. If you have questions after today, feel free to reach out to Danielle or myself. Happy to answer them. Those are our emails. But with that, we're at, I was gonna say 6:57 because I am still on the East Coast, but that's not right. That's 12:57 for all of you over in Hawaii or in the morning. So anything that you, any questions or anything else that you want us to talk or ask us about while we're here? And again, thank you for joining it. This is great. 120 some people. That's amazing.
I see Renata has her hand up. Hi, Renata. Again, you can unmute yourself.
Oh, hi. I just have a question. I wrote in the chat regarding my question regarding the laws and if they're different from like what the provider is able to provide in the state that they're providing care and versus what the patient is seeking. So I'm assuming that if there is a disconnect between what the provider can do for the patient or what the patient wants or whatever the care that's being sought and needed is, that doesn't fall within the range of the state or whatever the laws are where the patient is being treated. What is the best way to go about that? Because there are so many different opinions about this now, and the laws that are coming out are just, there's so much to keep abreast about and up to date about. And I'm just wondering how to take all that in and provide the care that is probably not going to fit within those boundaries. Like, I'm sure I'm not the only one that has this question. Like, how do we address this? Is it the patient has to go and write a law or seek a bill, or the provider, or both? Or like, I mean, that just seems like the things that happen in the legal system are so slow. And so I'm just trying to figure out how to do this in a timely fashion.
If you're not, I don't know if I'm going to answer all of your question correctly or not, but I think one of the biggest things is advocacy is on all levels. And so being part of your professional organization who is most likely doing lobbying or other services on behalf of your profession, for social work, that would be NASW, but the Nursing Association, the Medical Association, all of them, right? Like, they all are doing things to get information out there and providing testimony. I know the universities do as well. I think that's one of the biggest things to start with. And working, I mean, you will most likely have very active or socially active clients, and helping them to do it, but also providing testimony if you can. Again, I speak about our association. They send out calls to submit testimony. They give us templates for things. They encourage us to do so. So I would use that as part of it, because there's and again, the interview that John Stewart does with the Attorney General from Arkansas, it's just crazy. I don't know how else to put this. I was flabbergasted, actually, I think is the word, just in terms of what they were taking in terms of medical expertise, though all the medical expertise is telling them like the exact opposite of what they did. So Danielle, have you anything you would add?
Yeah, no, that's great. I think always looking at your professional associations, but I think on an individual level, there can be this level of like, I want to provide this care. It's also might not be legal in my state or in my jurisdiction. And I think that's when we really start to look at like, okay, well, here are the parameters we're working within. Do I know somebody who's doing this work in spaces that it is legal, right? Like I mean, a lot of the individuals I work with are in the South, and, it's navigating those really tricky laws that could put providers in really sticky situations, but also could, you know, we're talking about terrible impacts for their patients as well. So I think that like being real. So a lot of the times I think we're saying, here's what we can do. Here's what we can't do. Here's a starting point. What does that sound good to you? I think a lot of the times people think of that either or, it's all or nothing. And I think a lot of the times care is steps. It's, there are iterations. Okay, well, here's where we're at. Here's what we could do together. And like, how does that sound? I think a lot of providers tend to get pretty scared and offer very little. Instead, they could be checking in with them and being like, do you need mental health support? Like, what exactly are you getting that you're not, are you looking for that we can't do? And finding some more information. Like for me, I feel like I always am just gathering information. I'm like, okay, what is the law? Staying current. What are the ramifications? What does my agency say? What does my license say? I think always going by those kind of guidelines, but also always including the person you're working in partnership with, because it is an honor to work with individuals. And so, yeah, that's where I would start if it were me.
The individualization of care, I think, is important to remember. Not everyone wants every single thing.
Absolutely.
So just to echo Danielle, just having that conversation, what is it that you're hoping to do? What do you want for your care, and how are we going to get there? Is it something we can do right away, or is it something that's going to take time, or what are the steps? But not being afraid of the conversation.
I mean, working in partnership with people, I think it kind of levels that playing field. Like we might have the knowledge and power, but they're also experts in who they are. And so I think working a lot, like they're one of our greatest resources. And also like it opens out that dialogue and instantly builds rapport, because I care what you think. I care what your experience is. And as a provider, how I move through the world, as a helper, I am establishing that with you. And I think, the doctors who are doing it well, they're asking a lot of questions, and they are oftentimes, okay to not know, but letting people know they're still there.
We don't want to keep you longer than you probably have time. So thank you so much for the opportunity, though. We're grateful for this. Yeah,
Thank you both for being here. Look at all the thank yous. Check the chat. I know you guys have been awesome at keeping updated on that. So many mahalos and thank yous. We would love to have you guys back. You guys had started such great conversation, and it seems like there's a lot of questions and maybe a topic that needs more deep diving into, it sounds like. But thank you guys both, and I hope you have a good sleep.
Well, it's 7, it's not 12, like the street lights.
She's referencing that I've been up for a very long time. I flew overnight
yesterday.
Thank you for that. I appreciate it.
Thanks so much for everyone's engagement as well. These aren't easy questions. This is messy at worst, and violent, or like messy, and it can be violent, and and it's scary for people. So it's such a good space to host it. So thank you, Summer, for hosting that, and Robin for inviting me with you.
Thank you, everyone. And thanks for everyone who stayed on the call.